The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Advancements in Treating Glioblastoma. Thank you to today's webinar sponsor, Novocure, for their support of this program. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Jonathan Sherman is a board-certified neurosurgeon specializing in neurosurgical oncology. Recently, Dr. Sherman joined Rutgers Robert Wood Johnson Medical School as Professor of Neurosurgery. He also serves as the Division Chief of Neurosurgical Oncology at Rutgers Cancer Institute of New Jersey. In this effort, he leads a multidisciplinary team and robust translational research program, as well as a clinical trials program. Dr. Sherman is a pioneer in the use of new healthcare innovations such as virtual and augmented reality to improve the outcomes of his patients. He is a true clinician scientist working from the bench to the bedside as he performs translational research in an effort to provide a direct impact and advancing treatments for his patients. Thank you so much for joining us, Dr. Sherman. You may now begin your presentation.
Well, I greatly appreciate the opportunity, Umbreen, and the ABTA for the opportunity to speak to you today, as well as our sponsor, Novocure. So as Umbreen mentioned, I just recently started at Rutgers. I've had a very fortunate and long history of working with neuro-oncology patients, and this talk kind of represents what's out there, what our goals are, and the future in treating a very difficult disease. So I do present some disclosures. None of them really have any impact to today's talk. I recently was on the advisory board for Hoff Intelligence, which is an augmented reality company with a small amount of shares associated with that. I eventually will become CMO of PlasmaCure, which relates to a product I'll discuss later as part of research, but I've yet to sign that documentation, so I'm not officially affiliated with the company. I'll mention this slide. I would be remiss to say that we all come from our from giants that have trained us. Dr. John Jane Sr. was my giant amongst many people I was very fortunate to train under. He is one of the world's leaders in neurosurgery and also in brain tumor work. And he passed in 2015, ironically enough, from a glioblastoma. And he was a very big advocate of teaching. And so as I'm developing programs, especially being now at Rutgers and leading the charge for our brain tumor program, having someone like Dr. Jane as a mentor that taught me it's important to train those that come after us, because those are the people that are going to be treating the patients of the future. This slide actually relates to a paper that was published by my colleague, Dr. Jason Sheehan. He's a mentor of mine, a mentor and now colleague. He and I work closely together, but his wife passed about a year ago from metastatic lung cancer, and he published this just talking about how as important it is when you're on the patient side of things, especially being a clinician, to really see what that multidisciplinary care is. And so when we're treating brain tumor patients, we know very clearly that patients do, especially glioblastoma, patients do better if they have a more positive disposition. It can be very hard to do that when you've been diagnosed with a malignant brain tumor. But if you have a team that's really from A to Z, from the time you get diagnosed, giving you those alternative treatment modalities, even such things as meditation and herbals and things like that. But getting out and being part of the community and things that they do, you really need that team to kind of get you through the process, because it's more than just the chemotherapy, the surgery, and the radiation. So going to glioblastoma, and we talk about primary brain tumors in 2024, 25,000 new cases were predicted with over 18,000 deaths. But if you look at the numbers, it's pretty small, right? So new cancer cases really just over 1.3%. And when you look at primary malignant gliomas, more than 50% of those. So while we're talking about glioblastoma today, and still the median survival is 12 to 18 months, I'd say on average in my patient population, we're talking more around 2.5 years, but this is what the numbers look out, nationally, internationally. We can't forget about the lower grade tumors, even the grade 2 oligodendrogliomas, where median survival is still less than 2 decades, and we really have a long way to go. But when we're talking about malignant brain tumors, why is there's so much literature on glioblastoma? Why is there so many clinical trials? Well, you have to have volume, right? So if you have a small subset of tumors in general, and then you have a small subset of that, such as ependymoma, 6%, it's hard to get grant funding when you're going to have trouble having a patient volume unless you're doing a multi-center trial. So glioblastoma is the lion's share of that, which is why we have so many papers that relate to that, and so much grant funding is focused on that. And so then we talk about extended resection, just as a general slide that Ed Laws gave me a number of years ago. And, he's a world-renowned pituitary surgeon. And this was just saying, well, it's really hard to do a randomized trial for extended resection, because you can't really say, I'm going to only do a partial resection on you, but I'm going to do a full resection because that's what the trial said. But generally speaking, when you look at the non-randomized papers, there is a favoring extended resection. And, there's a paper that came out from the MD Anderson group in 2001 that it was a mixed population of gliomas. And this is where we originally had like a greater than 98% resection that we were advocating for. But it was a mixed population. The question is, do we really need to resect nearly all the tumor to make a difference? And on top of that, for elderly patients, the gestalt was, well, if you're over 65, should we just be doing a biopsy, and, they're not going to live long anyway. And the reality is that's not true. I mean, what really comes into play is your performance status. So we talked about the Karnofsky performance score and really extended resection, that if you can maximize extended resection for with a healthy elderly patient, then your progression-free survival and overall survival will actually be quite positive with a higher extended resection, as long as you're maintaining that the performance status and their quality of life and their function. And so, there's another paper that came out of the UCSF group back in 2011, where they were looking at a homogeneous 500 patient population. We really, in this case, they broke it down and said, all right, well, if you can get 78% resection. So it's not the exact number that matters. It's just saying, if you can maximize total resection with minimizing morbidity, we call this, which was coined by my colleague Mike Segru, who's now in New York and who was overseas for a number of years, and he's a fantastic neurosurgeon and tumor surgeon. And he coined the phrase oncofunctional balance. So, the onco is the tumor side, the function is the function side. So you have to understand that nuance between one side versus the other of maximizing the resection without hurting patients. And so if we're going to do that effectively, then we have to do that with adjuncts. And, the good news about neurosurgery is a lot of people like to work with us on the industry side. So we have a huge smorgasbord of opportunities to work with these companies. And so we're going to go over some of this today. So there's multiple talks that are affiliated with each of these different topics, but we're going to kind of go through the smorgasbord of those type of topics to help you understand what these technologies are and how they impact things. So we have anatomy, invasive functional mapping, intraoperative tumor fluorescence, non-invasive mapping, and then minimally invasive approaches. So if we go to anatomy, a frame-based neuronavigation. So if you look at this frame, this is the Horsley-Clark stereotactic frame, and this frame was originally designed for monkeys, and then we took that and we said, all right, we have the Lexell frame, so we're putting a frame on, we can stereotactically place a needle anywhere in the brain, and then we talk about surface-based fiducials. So these are little wafers that we put on the head, and then we can localize where we are in the head. We can minimize our incision, so suddenly we have a smaller incision because we can localize exactly where the tumor is. Then we have these little eyes that kind of can see exactly where we have this little wand in our hand and tell us where we are. So then you say, I can get a nice resection. Well, what's the problem? So if you're perfectly supine, just looking straight up in the air, or perfectly prone where you're looking straight at the ground, then you minimize what we call brain shift. Because as soon as you open up the skull and the dura, particularly CSF, comes out, and the brain shifts. And even to a small degree, it can shift. So, it's not necessarily practical to be in those two positions where, by the way, you still get brain shift. So if you suddenly have to have a person on their side or something like that, then you get into a lot of trouble where you think you are in a certain part of the tumor, and the reality is you might not be. So what do? So we interact with intraoperative MRIs. This is the original double donut that was up in Boston. So originally like a 0.5 Tesla MRI now, or even less than the original designs. We get to 1.5 Tesla. You can really start seeing what the tumor looks like, and then we have something like this is the MRIS system, where, the actual MRI comes to you. I was up at Memorial Sloan Kettering Cancer Center for a fellowship. They back then, this was in 2010, had a different system where the actual machine rotated, the patient rotated towards the. So there's different ways to do it. And you say, oh, well, this is great. I mean, the literature says, I get better resection, I meet my surgical goals. Well, I think that, you have to be careful with this data. Like anything else, you have to really look into the data and say, all right, well, what does the data mean? So if I don't have intraoperative MRI, which after a fellowship, I haven't had that now at Rutgers, I do, but I had to find other ways to get good resection. So we would resect until we thought we were done with the tumor resection. Well, if you have a intraoperative MRI, not saying everyone does this, but I saw in practice, you might stop earlier than you normally would. So, let's see how much tumor we have left. If you do that and you do a scan or two, then invariably your data is going to show further resection. But would you have gotten the same resection if you had waited like you didn't have the intraoperative MRI? So there's no way to absolutely glean out those confounding variables, but that, as I said, we have to take the data for what it is. So then we have to look at other options. So this is something that, that I've been very big advocate for. There's two different companies, that the main ones for brain and spine, Aloka and BK. We use the BK. This is what their probes look like. So this is the brain probe. This is the hockey stick spine probe. And what you get is this echogenicity. So you get this hyper-echogenicity where you get this increased white signal. And so if it's a defined tumor, like a meningioma, well, that could be easy because it's definitely bright and white. The problem is that, like, if you have a glioma, sometimes it can be very wispy. You kind of don't get that definition. And what I find is that for like glioblastoma, it can be very defined. But once you get radiation treatment effect, like after you've resected it, you get treated with radiation, typically you don't have that definition. So you can, see that can help you in differentiating, where I had resected a already radiated tumor in the past, and the part that was active tumor was hyperechoic, bright white. The part that was radiation was darker. So it helped me, when my navigation was with the shift was a little off, it helped me. The things you have to be careful of, you can put Surgicel or different adjuncts in the base of the resection cavity, which can actually help stop bleeding, but also can give off artifacts. So you have to be careful with what you're looking at. So then we talk about invasive functional mapping, and here's a brain. Sorry for those, that aren't used to looking at brain pictures, but, we put this strip down to actually say, all right, well, we want to put this strip across the central sulcus, for instance. So if we're putting this from motor strip to sensory strip, then we look for what's called phase reversal. And when we stimulate on this strip, where that phase reversal happens, that's what it looks like with the monitoring person. He goes, yep, it's between, 5 and 4. Then that's where your maybe your motor strip's on 5 and your sensory strips on 4. And then we can do the direct electrical cortical stimulation. And so, and that's where we stimulate the brain. Now, going back to this picture, this is, well, the other thing we can do with this is we can check for seizures. They're called after discharges, which are pre-seizure type events. So if you only have a strip, you might only be monitoring in one portion of your brain. But if you have a circular, this is from Alfredo Quinones down in Mayo Jacksonville. If you have a circular device, which it's not readily available yet, then you can actually test for after discharges while you're resecting. And I've actually had a case before where I had a patient had pre-op seizures with the glioma. I didn't have this. I had the one line, but there were after discharges. Once I resected the tumor, the after discharges went away, and the patient post-operatively had no more seizures. So, this can be very helpful. The other thing we do is, you saw the double tip bipolar stimulation. So that actually has a current going between the tips, but you also can have a monopolar stimulation. So what we know is, when we're on the surface of the brain, I typically use the bipolar. It shows me, all right, this is motor, this is, whatever I want to test out. Once I get subcortical, there's good literature that says with a monopolar stimulation, which is just sending electrical activity, and that electrical activity can spread. And what bears out is, if at 5 milliamps you get positive, let's say, motor findings, and that says you're about 5 millimeters from the tumor, 10 milliamps, 10 millimeters. Now, in the past, we've had this separate stimulator. There's actually this company that I've tried once. It seemed good. We're going to try it again. But at their tip, they of the suction, this is suction, you actually get a stimulator too. So you don't have to take it out every time you want to stimulate. So that's something that we'll be testing out at Rutgers, and I've used when I was at WVU before Rutgers. Now, then we talk about mapping. So first we have motor mapping. This is a positive map. What I mean by that is you're positively finding areas like motor and sensory, and then you do your tumor. A negative map is where you would just expose this area, and you say, yep, all this is negative. Oh, there's one area that's sensory or something like that. So that's a negative map. And you can resect your tumor. You can map out Broca's area, see where Broca's area is relative to where your tumor is, and so if you're going to do that, when I got to WVU, I was on our second Eastern campus, and we hadn't really done much tumor work there, much less awake surgery. So if you're going to do something like that, you have to have a protocol that makes everyone comfortable. So I designed a protocol that, that I said, well, if I want to do awake surgery, I don't want to just have a neurologist maybe talking to these patients. I want to have a robust neuropsychological protocol. So I have a neuropsychologist preoperatively evaluate a patient, intraoperatively know which tests we should be doing of the armamentarium. The typical test for awake surgery is just motor mapping, maybe sensory, and then picture naming. But there's many more tests that are more robust than that. And then post-op, we can see how the patients are doing. We have to know what our stimulation protocol is. Our anesthesiologists really want to know who should we not be bringing. Do they have sleep apnea? Are they obese? And so that kind of thing. So we designed that out. Ended up being about a 25-page document. Everyone was comfortable. We're doing awake surgery suddenly. And, I had been doing this for years at GW. I was at, after fellowship, GW, WVU, now Rutgers. So GW, I was used to doing awake surgery. Now I've gotten WVU used to doing awake surgery. And now we're going to be doing the same protocol at Rutgers. So we presented this a couple of years ago. And we linked with a group down at Mayo Jacksonville, and then our team at WVU took this on. And essentially, it was a free program called NeuroMapper. And all it is essentially putting neuropsychological testing on an iPad. So then the patient can see it, and then we can see it, and we can actually, neuropsychology is very quantitative. And so the nice thing about this is you get your quantitative data all ready for you, and it's not pen and paper. So this is what we're doing routinely, and then we can study the different aspects of neuropsychological deficits with our brain tumor patients using this modality. And so we'll talk a little bit about that later in what I'm calling translational research. So next is intraoperative tumor fluorescence. So there's different fluorophores. The traditional one's called fluorescein. It's a yellow fluorophore that kind of bleeds into everything, meaning that if you take a little time with it, suddenly to me everything looks kind of yellow. There's people that love fluorescein and nothing against it. It's just not my thing. So I was part of the original FDA approval for Gliolan or 5-ALA, and it's broken down by the mitochondria and tumor cells. And so when you have this brain tissue that looks kind of like gliotic, this is the edge of the tumor. This pink area under a blue filter, that's tumor. And so progression-free survival is about, a little bit of a bump here, but you actually get improved overall survival, and we correlate that with increased resection. What's the downside? If you're not careful and you plan things out, you can have microscopic disease burden that suddenly you can unroof a ventricle you didn't plan on. You can, if you're not careful, be in motor strip when you didn't plan on doing that. So you have to be very cognizant of where you are relative, and that's where some, stimulation and things like that are very helpful, because you can kind of reset where you are. Also, at very low values of Gliolan, you might not be able to detect it. And so there is a role for micro detection, and there's some different centers in the country that are working on those devices. So this is a tumor that's called a butterfly glioma. What it means is butterfly is it almost looks like wings here. And so this is where one of my colleagues did this case, and he sent me the video. And so if you look here, this is another view of that. So essentially what they did was put a tube down, and you say, all right, well, I want to biopsy this mass. And you put the tube down, and now you say, so this is the normal tissue. It's nice and white, and it's actually normal tissue not near the tumor. And so this patient, the Gliolan is like an oral agent, so you actually drink it. It's a little bitter. And so the patient drank that, and then when they went under the blue filter, so imagine it's a microscope. And the microscope is like just a regular light. You push a button, it becomes, you're looking at kind of dark. And then anything that is actually tumor becomes pink. And so here you say, yep, that's the tumor. And then I can have easy access to biopsying this tumor. And so that way you can guarantee that you're biopsying what's actively tumor. So hopefully that makes sense on, its value. Now, the other thing is that you don't have to read through all this, but as I mentioned, if you don't have a lot of that particular molecule in your body, like the tumor cells, there's only a couple in certain part of the brain, then you can't tell if there's actually tumor when you actually think there might be. So you can use another drug that makes the tumor look white. So all that's saying is that it's called dual fluorescence. So you resect you remove the tumor, you take out the pink stuff, and when the pink stuff's gone, you give them this other drug, and then anything that's left over turns white. So then you can really maximize your resection when the brain itself kind of looks normal and it's hard to tell. Because when you get to sometimes the tumor, especially in gliomas, very obvious what the tumor looks like. Once you resect it, the tumors kind of have fingers, and so what can happen is it looks like you have normal brain when actually there's tumor there. So these fluorophores, these bright areas, pink, white, can help us understand. As I said, there's another one called fluorescence, a yellow. So it's another color. The problem is, as I said, it can kind of make everything look yellow. So I tend to like this pink one called Gliolan or 5-ALA. And it helps us really understand how to resect and how to remove tumor from a patient. The other thing is that, you don't have to read through this, but bottom line is this drug can make you very light sensitive. So for 2 days, when you take the drug, you need to it doesn't affect you from overhead lights like fluorescent lights, but ambient light, like coming from outside, it can actually make you photosensitive. And so some people were smart about this and said, what if we actually resect tumors and then give light to the tumor, and it's called sonodynamic therapy. You're giving light, and that light is killing tumor cells. So there's a bunch of different trials in trying to figure out how to do that. And so that's something that we're looking at bringing to Rutgers to kind of not only remove the tumor from what we can see, but use a little bit that's left in those tumor cells we can't see to kill additional tumor cells. So the next thing is, no, there's nothing to really read about this. This is just the semantics, but it's called functional MRI. So when you go into MRI, you're actually moving parts of your body to tell us where you are. So it relates to the oxygen levels in the tumor. And so if you're lifting your left hand, you can actually say, yep, that area of the brain relates to motor function. Or here, that we have, it's called this homunculus. It's an area of the whole part of the brain. Part is hand, part is motor, part is face. But so by tapping your finger, we can say, yep, this area lights up. And so you can see something like this spot is what's called Broca's speech area. So that's where speech is. And you can see this is where the tumor is. You remove that tumor, and then you can do the same test post-op, and you can say, oh, look, the speech area moved to a different location. This is actually where it's supposed to be in most patients. This is where it got moved to. So that can be very helpful. DTI, there are highways in the brain. Highways in the brain that connect one part of the brain to the other. And so here's there's lots of different ones. And they have all these fancy names. And so we have association, projection, commissural. It doesn't mean a lot, because what you get is this massive amount of highways. And if there's a tumor in there, we want to know where that tumor is relative to these highways and these functional areas, because we want to be able to protect those areas to keep patients from having problems after surgery. So then you can take something like this, where you say, all right, well, there's my tumor. And here's my highway for movement, called the corticospinal tract. So there's my highway. This area here is for speech. This area here is for motor, which is right next to where those highways are. So now I know, hey, that gives me a lot of information on how I can remove that tumor safely. And then you can have something like this, where here's a tumor and here's 2 tumors. And you say, all right, this is those highways that let me move my arm or leg, right? So this tumor is splitting those fibers. This one is behind those fibers. So that's good in some respects, but what's back here is sensation. So if I remove this one, I have to remove it piecemeal. I have to take it kind of small bits at a time, because if I start taking out those fibers, I'm going to make somebody very weak. On this side, if I remove this, I'm not going to affect the motor stuff. I'm not going to affect how they move, but I'm going to really affect their sensation. So giving this type of information helps me plan out surgery, but also helps patients understand what their risks are going into surgery. And so we introduced a technology called surgical theater. This is a patient with a headset on. This is one of the first patients I treated at GW. And what we found was me hand waving and trying to explain stuff to patients was very difficult. But if I actually used virtual and augmented reality, patients could fly into their own head and better understand. And we could train our residents and medical students better using this. So this is how we kind of used to explain. This is a 2-dimensional image of the brain. And now we do something like this.
See all the different structures as we're trying to avoid them. So this is the mass. That's the tumor that we were biopsying. Mm-hmm. This pink area is your motor fibers. So that's those highways that we were talking about. Mm-hmm. This is that important vein that we wanted to avoid that we're going behind.
So that's how we explain to patients now. Then you have something like this. Suddenly you have this 3-dimensional view. And then we can pick out different trajectories. How are we going to biopsy this? How we can see what the brain actually looks like, which really helps us. And then we can give something like this. So patients always want videos, right? They want to see what we're dealing with. And so this is like a tumor that, in the 2-dimensional space, that's what it looks like, right? Well, what if we could reconstruct it so a patient really understands what we're dealing with? And so then you have something like this instead. And now you can say, all right, well, we did initial biopsy. You can kind of see where those staples were. We have this large mass. This is a glioblastoma. We can see where those highways are. We can see relative to those highways. And each of these highways have different functions. So we can say, yep, this highway is right next to the tumor. So we can say, all right, this is related to speech. So we know that that's important. So we really can map this out ahead of time. And then we can link it to navigation. So we take this wand to tell us where we are. We can show what our bony removal is going to be to get there. Then we can go in the operating room and we say, all right, here's our bipolar stimulator, that thing I mentioned earlier. Now we're going to be in the brain and we're going to be stimulating. So yep, that's going to be an important motor area. Then we can go, this is what we see with the brain. Now we can go under blue light, what I talked about with the glial, and we say, well, I don't see anything pink here, so no tumor there. But wait, oh, there's some pink stuff. So that's the tumor cells that's left over. And so that can give us a perspective. And then, and then afterwards, we can say, all right, well, can I tell how much volume there is? Well, we can work with our neuroradiologist and say, well, that's the amount of tumor we had to leave because we didn't want to make the patient weak. And then on top of that, we can compare, that's what we started with, and this is what we have now. So patients can really see how much we removed. And we can see that too. And so we have a room, patients sit here, they see their own imaging. This is kind of a touch screen that I can manipulate from my chair. This is actually a clean box. It uses like UV to clean the headset for each use. We actually can bring it into the operating room. So then we have a tumor like this where you can see the tumor augmented reality. You can actually see real anatomy, like the bone and soft tissues and things like that. And you can virtually put the tumor through. So you can say, all right, well, this is bone right here. So this patient had a repeat surgery from someone else had done it previously. They didn't remove enough bone. It was a little confusing with the anatomy. So now we know we need to remove more bone. And then we can see the tumor. So we can do that with this system. Then we can actually really upgrade. There's newer technology for these highways. So all of these different areas are networks in the brain. We don't really understand the real impact of these networks yet, but we know that they exist functionally based on what was called the Human Connectome Project. So that's a project where, we defined all of these connections in the brain to say it's more than just the motor, the ability to move and speech. What about if we're an executive, that's not why this was named, but if we're an executive, how do we go back if we remove a tumor and be able to think properly to do our job as an executive, as a lawyer, as a doctor, or whatever? And so how do we do those things? How can we count cash if we're working in a place where we're an accountant or cashier or whatever, and we have to be able to do the counting properly and keep track? Can we do that? Which of these networks relates to that? So then you combine something like that, and then you have, something like a tumor here, and you say, all right, well, now based on our networks, we say, here's like these spots on the surface of the brain. So these are all areas that work with language. And these are all deeper areas, the highways. And if we want to preserve those and we want to remove something like this, then we need to be able to map it out. And then we need to be able to see where that mass is relative to those important areas. So we can do a big opening like this. We know the highways are up here, but this thing came right to the surface. So we could actually resect, we could remove it without even touching the brain. And then we can see, well, with our little wand, we show where we are in space. We can say, yep, we were deep inside the tumor. And so that, that can help us. And then post-op, we can show the patient what we did. And then you can see, yep, this is what your incision looks like. We had to drill bone away. Well, now you can see how we fix that. So that kind of stuff can help the patient understand and things like that. And then we try to justify to our accountants, how do we, into the hospitals, how do we pay for this? Well, patients understand better. They typically stay at your hospital. So Hoag Hospital is out in Orange County, California. They're competing with UCLA and Stanford. They had a huge increase in patients that stayed with them because of this technology. And then you talk about this oncofunctional decision making. So, what it means is, if we know this is there and everything seems to be very important, how do we stay out of these areas? And how do we stimulate the brain so we know to properly identify these areas? So that can be very important as we're trying to now getting all new information about eloquence, what we mean by that is important stuff in the brain. How do we pick and choose what our approaches are to make sure that with this new information that we're not hurting those structures. And so, preserve the networks, those things I mentioned. What are the ramifications? Do we really understand what the real brain function is? How much don't we understand still? And so, then this is just examples that this is the tumor and this is those connections. You'll see these lines come up. In surgery, we just cut a tissue line between where those tumors are and where the important stuff is. So we avoid it. Same here. We're just making cuts in the brain so that these areas are protected. So we're separating the tumor away from the important areas. So if that makes sense. And then, so that's something we're talking about. So then we talk about minimally invasive approaches. How can we do this with minimal access? There's a thing called laser therapy. So in the MRI, we can tell temperature. So that's pretty much what all this says. We can tell temperature. So you can actually put a laser into the brain, and this one actually has a little robot. So the robot will pull the laser back, and I can burn tissue, and the MRI will tell me, all right, not too hot, right? So this is called the NeuroBlate system from Monteris. And there's a whole workflow. You have to put the laser in, you have to go to MRI, you have to make sure you're set up properly. It's a small little stab incision. There's two different types. There's types that can heat up like this. There's types that they call it a side fire. They heat just in one direction. There's a whole another company called Visualize. It does the same thing. This one doesn't have the robot, so we have to manually pull it back. There's different ways of saying, I can burn the tissue and minimize, injury. And so here's a 42-year-old that presented with some facial pain, some tingling in the left arm and leg, and they say, all right, well, what's the imaging show? So this is what it shows. When this patient originally presented, it was about this big. It was just a tiny white spot in the brain. And they thought it was some type of neurologic condition. They thought it might be multiple sclerosis, some other thing. So the patient got followed. They got worse. Imaging showed this thing grew. And so they said, well, what do you do about this? Back in the day, we would put a needle in this, biopsy it, and then the patient would get chemotherapy and radiation because you couldn't really get this deep in the brain without hurting the patient. And so now we can so this is an example of that laser going in. Now, all of this tissue is getting burned. And so this patient lived about 2.5 years. For doing a biopsy, that would be typically less than a year survival. So we gave, I can't say what the patient would have done if we had not done the laser treatment. But invariably, this patient would not have lived as long. And what it initially looks like is something like this. You get this burned, and this looks kind of awful. But about 2 months later, you couldn't even tell we had been in the brain. And that's how it looked for about 2.5 years. And then the patient had a rapid progression and unfortunately did not live beyond that. But the patient did have very high quality of life for a very long time. And so there's lots of literature out there saying, is this good? What patients should we be using this on? So we're still going through that to help understand what we're doing. And then we talk about keyhole surgery. So if you have something, what I mean by that is if you have something on the surface of the brain, you make a small opening, you're not going to be able to get there. But if you have something deeper in the brain, a small opening, you can get to exactly what you need to do. So here we probably need to make a bigger opening. So then we say, well, also, if we're going to do a small opening, we call it keyhole. If we're going through the keyhole, well, is there a guy behind the keyhole holding an axe? So you got to be very careful that you don't, that you don't have tumor over here that because of your keyhole, you're missing part of it, which can happen. And so all these different ways of doing minimally invasive surgery. And here's an example. There's a patient, 72, has this deep tumor. This is on the actually left side of the brain, near all these important structures. You can take this tube like this, and here's an example of that, where you say, all right, well, I'm going to take a tumor like this, and I'm going to, make a small opening in the brain, and I'm going to, it looks large, but it fits well. I'll put this tube down, and now I'm going to use my navigation. Just like I showed those little markers in the head, and I take this tube in there, and I can get that in, and then I can remove the tumor. And then once you've removed it, then you can see what's your cognitive footprint. What does that mean? Well, the patient did well, had no problems, and there's a very thin, you can barely tell you were even there. And so that's something we can do. That's called minimally invasive. So now we know that even though we remove tumors, there's microscopic disease, all these little fingers in the brain of tumor. So we have to give other things like radiation therapy. So stereotactic radiation, that's focused radiation. There's sometimes we don't have to radiate the whole brain, we can radiate part. And there's all these different names you've probably heard about: gamma knife, cyber knife, zap, this LINAC, linear accelerators. There's all these different names, variant true beam. It doesn't really matter. What really matters is that they're all about, can provide pretty much the same treatment. And what it really comes down to is a good radiation oncology team, a good neurosurgical team, and those teams working together to develop a good plan of treatment. And then sometimes we don't even have to give external treatment. We can do something like this. So this is a little piece of tissue that has radiation beads in the tissue, and we can put that in the operation in the cavity that we've resected. And so this is data that just shows, instead of radiating like the traditional external radiation where all this normal brain gets radiation, you can really minimize how much radiation the brain's actually seeing. And so, and there's another way called intraoperative therapy. So you have this big device, has a little ball in the end. And what you can do is you can do your resection, you bring this thing in, and it actually can provide radiation to your cavity. So that avoids the whole brain, the radiation we're talking about externally as well. There's data for glioblastoma about this, and brain metastasis too. And it can actually be very conformal. So it can actually minimize radiation to the rest of the brain. So the last 10 minutes, we'll talk about translational research. So we have all these wonderful adjuncts we can do, but there's lots of fun things we can do I call them fun because we work with great colleagues to put our heads together and say, what can we do to move the needle on treating patients? And so we talked about all these networks. The FDA went to this company I mentioned 2 years ago and said, well, how do you know these networks really mean anything? And so how are we going to test this out? And so we presented this a couple years ago and said, well, maybe our traditional tests, neuropsychological tests, aren't good enough. So maybe we need to design novel tests so we can really test out these different networks. Because in theory, we know what these networks do. Do we have tests that when we're in the brain doing an awake surgery, can we actually map it out? And so what we did more recently was, well, before we can come up with novel tests, let's look at all of our current tests. And let's try to say, of all these current tests, which ones do we think actually relate to each of these different areas in the brain? So I'm working with our neuropsychologists at Rutgers, and we're going to actually test this out and say, do we have good tests to understand where these areas of the brain are, so that if we want to understand where that executive network, as I mentioned, is, if we think we know where we are relative to it, can we test it out and prove that we're not injuring it? Because if we can do that, then we're making some headway. And so what we try to do is, to do that, we have to do fancy mathematics, and we have to be able to segment out the brain. We have to understand the surface of the brain. We have to understand how that surface relates to all those highways. We have to mathematically be able to tell, which parts of the brain, is related to these networks. For instance, the surface of the brain, we have to be able to say, what volume of the brain is that network in? And if the brain is being injured by tumor, is that network being injured too? And if we can give a number to how much is being injured, can we say, all right, this much is being injured. Does the patient show problems from a neuropsych perspective? Are the tests showing that the patient's having problems thinking straight? And so we're doing research now to understand that. And then I was involved with this whole extended reality initiative. So all that means is, we met with a bunch of companies, and we said, are there medical problems on the campus? This was at WVU and first GW. Are there medical problems on the campus that we can't meet because we are running into trouble with our current way of doing things? Maybe there's certain technologies that we can use, such as extended realities, like virtual reality, putting a headset on, augmented reality, like you're looking through a headset and seeing normal stuff. So that's kind of what we're talking about. So I presented this at Penn Medicine a couple of years ago, and there's a company that I linked with called Studio Bahia. And we were actually, before we started awake surgeries, we're actually studying anxiety, and can we use virtual reality to reduce anxiety for patients undergoing brain surgery? So that's one of the studies we're looking at. This is a video. This is just a health intelligence company. This is using augmented reality to put drains in the brain. So we actually can tell what the, when we're in the brain, we're looking at a patient, is that tube going in the right spot? So and we'd have to do that sometimes with our brain tumor patients. Now, the other thing, this is the company that I'm not officially a part of yet, but what we did was we looked at electrified helium. So essentially, we electrified helium and it made a jet, and it produced these reactive species, these species that can kill tumor. And we studied that, and we said, all right, well, if we do that, these are glioblastoma cells, these are normal cells. It was very selective to killing tumor cells. We added a drug called temozolomine, which is the standard drug for glioblastoma, and it seemed to work pretty well with this. We even developed a device to put in the brain. The problem was trying to get that to clinical trial was very difficult. Couldn't really do it. So we pivoted and we made an external system outside the head. So if, we actually proved that if you do this outside, now this is in the flank, but if you do it outside the head, you can actually show value. So this is how it looks. And you can actually show value where you can say intracranially, you decrease tumor volume. And so, then we linked up with Novacure. We've been talking about Novacure. They're a good sponsor for the talk today. This is something that's used readily for patients that has 3 to 4 months improved survival with this. And so the question is, well, can we do better than that? Every company likes competition. So we tested our device compared to Novacure. And this is their device, this is ours. And we said, all right, well, maybe we can do it for a shorter treatment time. So we studied this for blood-brain barrier, and it opens up the blood-brain barrier. So maybe we could do lower temozolomine doses. And we presented this at this workshop last March. Now, how do we build it? For those of you who know Back to the Future, this is a device that was for knowing your thoughts. But imagine this is kind of what we're talking about. We actually have a device where you want to be able to put it on the head and have those discharge tubes emit to the brain. And eventually, this is augmented reality. If instead of putting a whole head device on, imagine we can use facial reconstruction to see where the head is in space, and then we can hold a discharge tube and overlay it on the right where the tumor is, and then we can more effectively deliver our treatment. So that's kind of a long-term proposition. There's nanoparticle research. We have problems. We can't tell, treatment effect versus tumor. We can't tell how extensive the tumor is. We can't screen for things. We want to give nanoparticles with chemotherapy and improve the ability for that tumor to get into the brain across this barrier. So we're studying this. And so we published a paper like what nanoparticles can get to the brain safely. Will the nanoparticles kill like the liver if we give it? So we need to know toxicity. How do we image it, CT or MRI? So we're looking at that. And finally, looking at neurorehabilitation. If a patient, we talk about functional connectivity. If those highways are intact, but the patient still can't move their leg, why not? So there's a functional problem. So we're studying this. There's a thing called transcranial magnetic stimulation. You put this over the head right where you want, and you can actually improve outcomes. So you can do a sham procedure where it doesn't do anything. But let's say you do this transcranial magnetic stimulation. If you stimulate this area on the motor, it can decrease the side you're stimulating and increase the other side. And if you do it a different way, you can increase the side you're stimulating. So then if you look at different examples, if you have right-sided weakness, that's because work with me here. The right-sided weakness is because the left side is dysfunctional. So if you stimulate the right motor area, it will actually decrease the right side, increase the left, and therefore improve the right-sided weakness. Same with speech. Speech is on the left side. So if you stimulate the right area for speech, it will increase the left area, improve speech. And this, if akinetic mutism, that's where a patient just can't get the words out. And so you can stimulate this area of the brain, and by doing it, they actually can improve this. And these are 3 examples of that my colleague Mike Segura mentioned earlier is doing. So when we're talking about objectives, we're talking about if we're going to build a team and we're going to do this effectively, integrating cutting edge techniques and technologies for imaging, surgery, and adjuncts. And then we're offering a comprehensive collaborative neuro-oncology treatment plan. But that includes neurosurgeons, neurologists, neuropsychologists, medical and radiation oncologists, the research I mentioned, we have to have a coordinator. So it's a comprehensive team. So when you come in the door, first time ER clinic, you feel like you're getting taken care of, not just for the surgery, but for all the other things and the stresses you're dealing with. And by the time you get to remission, we're still there doing that and doing that help for you. And so bottom line is it's a comprehensive process. This is my family from a couple of years ago. I'm fortunate to have a wonderful family, very fortunate also to have a wonderful team at Rutgers to build this up. So, this is a quote that I found recently: no problem can sustain the assault of sustained thinking. To me, that means you have a problem. You have the right question, but you don't know how to fix it. You find a way, you build a team, and if it's not working, you pivot and you try again. So thank you for your time. I'm happy to take any questions.
Thank you so much, Dr. Sherman, for that wonderful presentation. As a reminder for all of our attendees, if you have a question that you'd like to ask, please type and submit it using the Q&A button, and we will answer as many questions as time allows. All right, so one of the first questions we have is asking about clinical trials. At what point should a patient with glioblastoma be considering clinical trials as an option for their care?
Sorry, I got a text about something. Go ahead, repeat the question, please.
We just have a question asking, at what point should a glioblastoma patient consider clinical trial options as part of their treatment?
That's a good question. So when you're talking about clinical trials, the problem is there's a lot of failed clinical trials out there. And so with failed clinical trials, it begs the question, should you be just doing standard of care? And so I think the key to me as a good clinical trial is one that incorporates the traditional treatment with Timidar and whatnot and adds an adjunct to that. So I think the key is, being in a location that if you have good clinical trials around you and you have a group that advocates for it, I think that that's a time to bring in clinical trials early if as a family member and see what's available. If there's not, I think the important thing is getting on treatment. And we don't have good clinical data for trials that are, that are out there that say this should take us from our current standard of care. So I would not advocate for going around the country and trying to go to 5 different centers and saying which clinical trial is best, because I've had patients do that. I've had patients get PEs, like emboli to the lung, because they're in the car and they have, with that you have increased risk of clotting because of that. And then that patient ended up on standard of care anyway. So I'd say my advice in a nutshell is, if you have something locally, if you have your team in your area that has a good trial, go for it. But if talk to the team there. But the real clinical trials are after you fail, then you go on to a trial that goes on to next level. Because after you get past Timidar, our treatments after that are pretty poor.
Thank you so much for explaining that. We have a question here asking about the fluorescent imaging that you discussed. Can you explain how fluorescent imaging works? How does the dye specifically target tumor cells? And then there's a second part to this question as well, if you're able to touch on, and that is asking why we're not able to use a similar targeting mechanism for treatments such as chemotherapy.
Yeah, so glialan is metabolized only by tumor cells in the mitochondria. So it's very specific, which is why it's nice. That's one thing I don't like about fluorescence, is that the yellow filter is not specific for tumor. So if you the people that use it, I'm not trying to dissuade people from, they say, oh, we use this thing called fluorescein. And you're like, oh, I heard Dr. Sherman talk. People that use it love it. It's the timing. If you wait too long with fluorescein, it tends to bleed into all the other non-tumor tissue. So you have to time it right. Glialan, the longer it's in there, the cancer cells have a longer time to metabolize the product, so you get more pink. So it's actually better if you wait a little longer. And so, so the reality is that, so that's why it's specific to tumor. But then the detection device, if you have very little metabolized, you might not see it even though it's there. That's why people are trying to devise these microdetector devices, because that blue filter might not see it, right? So the key is that you'd want to say, well, it's tropism, right? What that means is I give a drug, it goes to the tumor. So, that's where nanoparticles come in. Because in an ideal world, you're like, why can't I link something with this glialan and then it goes in and just kills all the tumor cells? That's a great question. And the researchers behind this probably know better than me. Why does that not work? Why can you not link? Because it has to cross the blood-brain barrier, and there might be an inhibition if a molecule is too big. So why you can't link something to glial to just automatically kill the tumors? Who knows? It's beyond my pay grade because I don't know the research to say there must be something that's inhibiting that linkage so the damaging chemotherapy, whatever you're giving, happens. Now, what you do see from what I was mentioning about photodynamic therapy is that we are taking advantage of what it can do, right? So glial has a photosensitizing effect. So let's kill the tumor cells through light, right? But what's the downside? So how do you deliver that light? So some of the trials actually have putting tubes into the brain and delivering that light through these tubes, but that could have a risk because you're putting these tubes in the brain. There's another device, which I'm not going to name because I'm not part of the trial and it's not readily available, but it's a balloon. You actually fill up this and then has a light emitting through the balloon. So you don't just remove the tumor, you have a cavity and you emit through that way. So that's how we're taking advantage of the photodynamic characteristics of glial. But that's why I think the nanoparticle idea is cool. I just have to have a nanoparticle expert, which I tried at WVU. We didn't have the perfect link. I've been trying again at Rutgers, but that's where I think that linkage can come into play.
Thank you so much. We have a couple different questions about necrosis that I'm going to try to put together in one. So first, can you explain what radiation necrosis is and what that might mean for a patient's recovery? And then the second question, follow up to that would be, are there any dyes or detectors that are used to identify radiation necrosis?
So radiation necrosis, so it's all this plethora, it's like a spectrum. So we call about tumor treating effect, pseudoprogression versus what is necrosis. So you look in the literature, you're like, I don't know what the difference that is. When you're talking about, when I talk about pseudoprogression or treatment effect versus necrosis, I'm kind of talking about, is the patient feeling it or are they not? And so if you have an imaging finding that says, is this tumor or not? Then, but the patient's sitting there and feels fine. That's when we're talking about, is this treatment effect or pseudoprogression where where it's bright and white on the tumor, on the imaging, but it's not actually tumor? Or is it, is it necrosis where you get all this swelling in the brain, the patient has bad headaches, they're having seizures or whatever, then you say, and then you biopsy it or whatever, and there's no tumor in there. And so the treatments for that, there are a couple different ways to do it. First of all, for treatment, if you're having a necrosis and your patient's symptomatic, what you can do is give them high-dose steroids. And so you give them like a high dose of dexamethasone, and then you titrate it really slowly. The problem with that, especially if you're diabetic, is suddenly your sugar's got out of whack and you have a big problem with that. And if it doesn't work, there are other things. You can do laser treatment. You can put the needle in and burn it. You can also give a medicine called Avastin. It's actually a drug that blocks fluid coming through blood vessels, so it takes the swelling away. From a diagnosis standpoint, that can be tricky. That's why I mentioned the nanoparticle thing. What we do right now is we can do different things. We can do perfusion. Perfusion is an MRI technique for blood flow to the brain. And so if you have increased blood flow to an area of the brain that you think is tumor, that's probably tumor. If it's dark, if it's actually less blood flow than normal brain, that can tell us it's probably necrosis. There's also a thing called spectroscopy, which tells us different chemicals within the area that we're dealing based on MRI. So we put little squares on the MRI and certain things that show peaks like that relate to normal cells that might say that, well, that's tumor. There's certain ways the peaks go that if the peaks look this way, that's normal brain. If they look this way, that's tumor. If these peaks, different peaks kind of link up, that's necrosis. So it's not perfect. And there's also called PET scan imaging that shows increased uptake from breakdown, like for metabolism, like, kind of like you eating an energy bar and the tumor breaks it down. Same with PET. So you take a chemical and the tumor breaks it down, and you can see bright areas in the brain tissue that says that's tumor. If it's dark when you give the drug, then that's necrosis. So that's kind of that. Hopefully that answers your question.
Yes, thank you so much. You shared a lot of exciting treatments in this presentation. Can you share some advice for our audience today on how to identify or find the best location for treatment, especially if they're wanting to gain access to some of the advancements that you talked about today?
I'd say the key is starting with your local hospitals. You know, you can start with your doctors. If sometimes, if you have friends that are physicians, they can link you up. But I think you can literally, mostly it's the academic center. So if you're in Atlanta, like you might want to go to Emory, but, Piedmont Hospital is building up their reputation. So you might even call and say, hey, start with your primary and say, do you know of anybody who do you recommend? If they don't get the answer you want, then you can start with an academic place like Emory, or in the New York area, you have a lot of options. So if you're in New Jersey, I'd like to say you could come to Rutgers. But if you're in New York City itself, you have Memorial Sloan Kettering Cancer. So you have a lot of options. So you can, but they're all, it's hard to get around New York. So you can pick the one that's closest to you. I think some of the key is literally pick something that's close to you. If you don't like the answer from your primary or your local doc, call up the academic center and say, hey, what trials do you have going on? Google's not our friend, right? You can get some bad information. You can see some terrible videos and things that have gone awry. But you can say, hey, I've heard that Piedmont, like in Atlanta, would you know Piedmont Hospital as a patient is good? Not necessarily, but you can Google it and say, hey, new clinical trials. Or you can even go on, Google NIH.gov and say, hey, what clinical trials? And you have to be a little savvy, but you can say, is there one in my area? And then you can say, oh, that's at Emory, or that's at WVU. I live near there. But the key is not traveling around the country for the best thing. Try to find something local and try to get in as soon as possible with them. And if you don't get an answer, try the other local, because there's so many cancer centers affiliated with smaller hospitals these days that you can invariably get good treatment, and it doesn't have to be at Duke, and Duke's fantastic. But if you don't live in North Carolina, you don't have to go there. You can get something locally at home.
Thank you so much for sharing that. We have a question here asking for a patient who has undergone recurrence, do you do multiple resections on patients like this, or is there a limit of success in doing surgery again?
My goals in re-resection is, am I giving some patient an advantage, right? So and a lot of that relates to new treatments. Like if we're going to do a second line treatment and the literature shows like, all right, with a medicine called lomustine, well, it's going to benefit us if we decrease the disease burden, or if we're going to do reirradiation with lomustine, if that's a second line treatment sometimes. And so we know that necrotic, that dead tissue, if we can remove it, patients will do better. If I don't have a good treatment option for a recurrent tumor, then other than giving something like a new medication, and there's no literature, there's not now that really supports it, I'm not a fan of re-resecting after re-resecting. I like to re-resect that gets us tissue and justifies another second line chemotherapeutic, a clinical trial. There has to be a rationale for doing it. It's not like see tumor, operate on tumor. It's, do we see a tumor, and do we have a plan with our comprehensive tumor board, our multidisciplinary clinic, with our medical oncologists, our radiation oncologists, that by doing this resection, we are going to make a difference for the next line of treatment? If the answer is no, then sometimes we'll just move on with a tumor burden and say, look, there's no role for more surgery, but we are going to get you onto a chemotherapy second line. So it's really patient specific, and that's how I approach it.
Thank you so much. We have another question here asking about the Optune device. Can you share advice on how patients can get access to Optune as a treatment option? Should they just talk to their neuro-oncologist about it, or what steps should they go about?
They should talk to the neuro-oncologist about it, because those are the ones prescribing it. And if the good ones that do it, there's about 25% not major skin issues, but you can have skin issues. So you want a neuro-oncologist that knows about it, knows about the skin issues, has a dermatologist linked in with them in case you have that. So really, the neuro-oncologists are sometimes the radiation oncologists, depending on your location, but you should have both on your team. You might not have a neuro-oncologist, it might be a medical oncologist, but the medical side and the radiation side, between the two of them, invariably in this day and age, one of them in any center you go is going to have access to Optune. And if they don't, you can even you can even go on Optune's website and say, hey, I live in the Atlanta area, I live in the New York area, New Jersey area, what centers around me are prescribing Optune, and you can find that. So I think it's good. You just have to understand that, you have to shave your head every 4 days, and you have to, wear it for a long period of time. So, and it does have survival advantage, but, you have to you want a team that knows the nuances so they can explain it to you properly.
Thank you so much. It looks like that is all the time that we have for questions for this session. I want to thank you again, Dr. Sherman, for taking the time to share your insight and expertise. And thank you to today's webinar sponsor, Novacure, for their support of this program. And also a special thank you to each and every one of you who joined us today and for sharing your wonderful questions. We hope that you found this webinar to be informative and beneficial. Before you go, we encourage you to take a few minutes to complete our webinar survey by scanning the QR code or going to the link on the screen. Your feedback is important to us as we plan for future programs. You'll also receive a link to the survey as well as a recording of the webinar in a follow-up email over the next few days.
Thank you for the opportunity.
Thank you so much, Dr. Sherman. We really appreciate you. If you're looking for more content like this, join the nation's largest brain tumor conference for patients and families taking place September 5th through 7th, both in person in Chicago and virtually. The ABTA's National Conference is a 2.5-day program packed with therapeutic workshops, educational sessions, research, fun, and most importantly, community. To learn more or register for free, go to bit.ly/2024NC. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. This now concludes our webinar. Thank you so much for joining us and enjoy the rest of your day.